Syncope. 1. What is the first step in evaluating loss of consciousness from syncope? The first step is to ensure that the person actually lost consciousness. Simply falling or being less responsive doesn't necessarily mean there was syncope. 2. What indicates true syncope? In true syncope, the person cannot hear people speaking to them. Also, urinary or bowel incontinence is too nonspecific to be helpful in diagnosing syncope. 3. How can we differentiate between sudden or gradual loss of consciousness? Sudden loss suggests a cardiac or neurological cause, such as arrhythmia or seizures. Gradual loss, likely caused by toxins or metabolic problems like hypoglycemia, hypoxia, or drug intoxication. Vasovagal syncope can happen either suddenly or gradually. 4. What does the sudden or gradual regaining of consciousness tell us? Sudden regaining points to a cardiac cause, e.g., valve disease, ischemia, arrhythmia. Gradual regaining, often seen in generalized seizures except for absent seizures. After a seizure, there's typically confusion that can last up to 24 hours, post-ictal state. 5. What should be noted about the regaining of consciousness in seizures? People who have seizures do not immediately regain full awareness. They are confused for a while afterward. 6. What should be checked if a person experiences sudden loss and sudden regaining of consciousness? Cardiac examination. If both the loss and regaining of consciousness were sudden, check the heart for issues. Normal exam. The cause could be arrhythmia, and tests like EKG, telemetry monitoring, and troponin levels are needed. Abnormal exam. The cause might be related to heart valve issues or other conditions like aortic stenosis, AS, hypertrophic obstructive cardiomyopathy, HOCM, or mitral stenosis, MS, which require an echocardiogram. 7. How should syncope be managed? Management depends on the patient's history and physical examination. Common tests: head CT, EKG, cardiac enzymes, and echocardiogram. Hospitalized patients. Cardiac telemetry is used to monitor for arrhythmias. Discharged patients. A 24-hour Holter monitor is placed to check for arrhythmias. 8. What is the main cause of mortality in syncope cases? About 90% of mortality from syncope is due to cardiac causes. Coronary artery disease, CAD. 1. What is coronary artery disease, CAD? CAD refers to a condition where the coronary arteries become narrowed, reducing blood flow and oxygen delivery to the heart muscle. It is also known as atherosclerotic heart disease or ischemic heart disease. 2. What are some non-cardiac causes of chest pain? When chest pain is not due to ischemic heart disease, common causes are gastrointestinal, GI disorders, such as GERD, gastroesophageal reflux disease, ulcer disease, cholelithiasis, gallstones, duodenitis gastritis. 3. How does the risk of CAD change with age in women? For a 48-year-old woman with no risk factors, it is very unlikely that chest pain is related to ischemic heart disease. However, after the age of 55-60, the rates of CAD in women equal those in men as the protective effect of menstruation and estrogen fades. 4. Do menstruating women experience myocardial infarctions, heart attacks? Menstruating women rarely experience myocardial infarctions because the protective effects of estrogen are still in place. 5. What is the benefit of exercise for heart health? Regular exercise, even simple activities like taking the stairs instead of the elevator, can significantly improve cardiac health and reduce the risk of heart disease. 6. Is myocardial infarction common in women under 50? Myocardial infarction is very rare in women under 50, which is the average age of menopause. However, this does not mean estrogen replacement therapy is helpful for preventing CAD. 7. Does estrogen replacement therapy help CAD? No, estrogen replacement may improve LDL, bad cholesterol levels, but does not help prevent coronary artery disease. 8. Do relaxation methods like yoga, meditation, and Tai Chi improve heart health? There is no measurable evidence that relaxation methods like yoga or meditation improve heart health. While they may help reduce stress, other factors like weight, cholesterol, LDL, and heart rate have measurable effects on heart health. 9. What factors are clearly beneficial for cardiac health? Factors such as weight management, lowering LDL cholesterol, and increasing heart rates through exercise show clear benefits for heart health. Do women or men have a higher risk of dying from heart disease? Over time, more women will eventually die from heart disease than men. This is because heart disease risk increases as women age, especially after menopause. Risk factors for coronary artery disease, CAD. 2. What are the most clearly agreed upon risk factors for CAD? The main risk factors for CAD are diabetes mellitus, tobacco smoking, hypertension, high blood pressure, hyperlipidemia, high cholesterol, family history of premature CAD age, over 45 in men and over 55 in women, renal disease, kidney disease. 3. Which risk factor is the worst for CAD? Diabetes mellitus is considered the worst risk factor for CAD. People with diabetes tend to have the highest rates of CAD over a long period of time, e.g. 10 years. 4. Which risk factor is the most common for CAD? Hypertension, high blood pressure, is the most common risk factor for CAD. About 20% of the population, or 60 million people, suffer from hypertension, and nearly half of them don't even know it. Family history and its role in CAD5. Does family history affect the risk of CAD? Yes, but it only matters if the family members involved had CAD at a young age, before 55 for men and before 65 for women. The closer the relative, the more important it is. First-degree relatives like parents or siblings. 6. What is considered premature coronary disease in a family member? Premature CAD refers to CAD occurring in male relatives younger than 55 years old, female relatives younger than 65 years old. Does CAD in distant relatives, e.g. grandparents or cousins, affect the patient's risk? No, CAD in distant relatives does not significantly affect the patient's risk, lipid profile and obesity. 8. Which part of a lipid profile is the most dangerous for CAD risk? Elevated LDL, low-density lipoprotein, is by far the most dangerous part of a lipid profile for CAD. High LDL levels contribute most significantly to the development of coronary artery disease. 9. How important is a low HDL, high-density lipoprotein in CAD risk? A low HDL is associated with poor long-term prognosis, but it is not as dangerous as having high LDL levels. 10. Are high triglyceride levels a major risk for CAD? Elevated triglycerides are potentially dangerous, but they do not have as strong a correlation with poor outcomes as high LDL levels do. Treating elevated triglycerides is not as beneficial as treating high LDL. 11. How does obesity relate to CAD? Obesity, especially when it causes increased abdominal girth, fat around the belly, is associated with higher cardiac mortality. However, the risks from obesity are often linked to other conditions like diabetes, hypertension, and hyperlipidemia that are more directly harmful to heart health. Less reliable but probable risk factors for CAD12. What are some less reliable but probable risk factors for CAD? These factors are not as clearly linked to CAD, but they are still associated with increased risk. Physical inactivity. Lack of exercise can increase the risk of CAD, but not as strongly as other factors like diabetes or hypertension. Excess alcohol consumption. Drinking too much alcohol may contribute to CAD, insufficient intake of fruits and vegetables. A poor diet can increase the risk of heart disease. Emotional stress. Chronic stress might contribute to heart disease. Elevated cardiac CT scan, calcium scores. A calcium score higher than normal on a CT scan of the heart may suggest heart disease, but it's still experimental and not fully understood. 13. Does physical inactivity strongly affect the risk of CAD? Physical inactivity does increase the risk of CAD, but it's not as severe a risk as conditions like diabetes or hypertension. However, regular exercise has clear benefits for reducing heart disease risk. 14. What is the significance of a calcium score from a cardiac CT scan? Calcium scores on a CT scan are still considered experimental. The test may show how much calcium is in the coronary arteries, which can indicate plaque buildup. However, it's not yet clear how to use this information, in addition to standard risk factors like blood pressure and cholesterol. Takotsubo cardiomyopathy. 1. What is Takotsubo cardiomyopathy? Takotsubo cardiomyopathy is a condition where the heart muscle is temporarily weakened and damaged, often following extreme emotional stress. This typically happens in postmenopausal women. 2. What are some common causes of Takotsubo cardiomyopathy? It often occurs after overwhelming emotional stress like divorce, financial problems, natural disasters like earthquakes, traumatic events like lightning strikes, severe low blood sugar, hypoglycemia. 3. What happens to the heart during Takotsubo cardiomyopathy? The left ventricle of the heart undergoes a condition called ballooning, where it temporarily enlarges and doesn't pump properly, leading to left ventricular dyskinesis, impaired movement of the heart muscle. 4. How is Takotsubo cardiomyopathy treated? Treatment includes medications like beta blockers, which help reduce heart strain, and ACE inhibitors, which help lower blood pressure and protect the heart. Revascularization, a procedure to open up blocked arteries, will not help because the coronary arteries are normal in this condition, unlike in other heart diseases like ischemic heart disease. 5. Can emotional stress lead to sudden death? Yes, extreme emotional stress or anger can lead to chest pain and even sudden death, particularly in cases of Takotsubo cardiomyopathy. Unreliable, unproven risk factors for CAD6. What are some unreliable or unproven risk factors for coronary artery disease, CAD? Some markers that have not proven to be reliable risk factors for CAD include elevated homocysteine levels, chlamydia infection, elevated C-reactive protein levels. These factors have not been shown to have a clear, consistent impact on CAD risk, and measuring or treating these factors is not helpful. 7. Why are some disease markers considered unreliable in CAD risk assessment? These markers, like high homocysteine or elevated C-reactive protein, have been shown to lack consistent evidence linking them to CAD. As a result, there's no benefit in measuring or treating them specifically. 8. What is a common mistake people make when answering CAD risk factor questions? A common mistake is misinterpreting family history. For example, if a patient's elderly relative had CAD, e.g., a mother in her late 60s, people might incorrectly assume it is a significant risk for the patient, even though the relative's age is outside the typical risk range. Smoking and CAD risk. 9. How does smoking affect the risk of CAD? Smoking significantly increases the risk of developing coronary artery disease, CAD. It damages blood vessels and causes plaque buildup in arteries, making the heart work harder. 10. What happens to the risk of CAD after quitting smoking? Smoking cessation leads to immediate improvements in heart health. Within a year, the risk of CAD is reduced by 50%. Within 2 years, the risk is reduced by 90%. 11. What is the greatest immediate improvement in CAD outcomes? The greatest immediate improvement in CAD outcomes is achieved by quitting smoking. Stopping smoking dramatically reduces the risk of developing further heart problems. Chest pain and ischemic pain. 1. What causes chest pain in general? Chest pain can be caused by various factors, but the heart, as a muscle, causes pain when it doesn't get enough oxygen. This leads to a condition called ischemia, where the heart muscle starts to hurt due to lack of oxygen. What does ischemic pain feel like? Ischemic pain is typically dull or sore, squeezing or pressure-like. 3. What type of pain is not ischemic? Pain that is sharp, like a knife, point-like, or lasts only a few seconds is not ischemic. Ischemic pain is not tender to the touch, positional, doesn't change with body position, pleuritic, doesn't change with breathing. 4. What are the key features that help tell if chest pain is ischemic or not? Chest pain that changes based on respiration, pleuritic pain, worsens with breathing, body position, positional pain, changes with movement, touch of the chest wall, tenderness. These features strongly suggest the pain is not ischemic. 95% of the time, if chest pain changes with these factors, it's not related to the heart. 5. What does a 95% negative predictive value mean? If a feature, like pain changing with respiration, strongly suggests the pain isn't ischemic, it has a 95% chance of being correct. This means 1 in 20 people might still have ischemia, but for exam purposes, like the USMLE, it's enough to exclude ischemia. 6. What is the most common non-ischemic cause of chest pain? The most common cause of chest pain not related to ischemia is gastrointestinal disorders like heartburn or acid reflux. 7. How common is it for chest pain to be caused by a heart attack, myocardial infarction? Less than 10% of people who come to the emergency department with chest pain actually have a heart attack. For 50% or more, there's no heart disease at all. Characteristics of ischemic pain. 8. What is the duration of ischemic chest pain? Stable angina. The pain lasts more than 2 minutes but less than 10 minutes. Acute coronary syndrome, ACS. The pain lasts more than 10 minutes up to 30 minutes. 9. What triggers ischemic chest pain? Ischemic chest pain is usually triggered by physical activity, cold weather, emotional stress. 10. What other symptoms may occur with ischemic chest pain? Symptoms associated with ischemic chest pain include shortness of breath, SOB, nausea, sweating, diaphoresis, dizziness, lightheadedness, fatigue. 11. How would you describe the quality of ischemic chest pain? Ischemic chest pain feels like squeezing tightness, heaviness, pressure, burning, aching. It does not feel like sharp, pins, stabbing, or knife-like pain. 12. Where is ischemic pain usually located? The pain is usually felt substernally, meaning in the chest. 13. What relieves ischemic chest pain? Rest often relieves ischemic chest pain. 14. Where can ischemic pain radiate to? Ischemic pain may radiate to neck, lower jaw, teeth, arms, shoulders, causes of chest pain, and their diagnosis. 15. What should you do if chest pain is accompanied by chest wall tenderness? If the pain is tender when you touch the chest wall, the most likely diagnosis is costochondritis. The most accurate test is a physical examination. 16. What if chest pain radiates to the back and there is unequal blood pressure between the arms? This could be a sign of aortic dissection. The most accurate test to confirm this is a chest X-ray, which may show a widened mediastinum, or a chest CT, MRI, or TEE, transesophageal echocardiogram. 17. What if chest pain is worse when lying flat and better when sitting up in a young person? This is suggestive of pericarditis, especially in someone under 40. The most accurate test is an electrocardiogram, ECG, which will show ST elevation everywhere and PR depression. 18. What if chest pain is better when eating and associated with epigastric discomfort? This could be duodenal ulcer disease. The most accurate test is endoscopy to examine the stomach and duodenum. 19. What if chest pain is accompanied by a bad taste, cough, or hoarseness? These symptoms are common in gastroesophageal reflux, GERD. The most accurate test is a response to proton pump inhibitors, PPIs, or medications like aluminum hydroxide and magnesium hydroxide, or viscous lidocaine. 20. What if chest pain is associated with cough, sputum, and hemoptysis, coughing up blood? These symptoms point to pneumonia. The most accurate test is a chest X-ray to check for infection in the lungs. 21. What if chest pain is suddenly accompanied by shortness of breath, tachycardia, and hypoxia? This may be a pulmonary embolism. The most accurate tests include a spiral CT or a VQ scan. 22. What if chest pain is sharp, pleuritic, worsens with breathing, and tracheal deviation is noticed? This could be a pneumothorax, collapsed lung. The most accurate test is a chest X-ray, features of chest pain that are not helpful for diagnosis. 1. What symptoms are not helpful in determining the cause of chest pain? Certain symptoms are common in many conditions and cannot help identify the cause of chest pain. These include nausea, fever, shortness of breath, dyspnea, sweating, diaphoresis, anxiety. 2. Why is nausea not helpful in diagnosing chest pain? Nausea can happen with many conditions, such as gastrointestinal problems, infections, or stress. It doesn't point directly to heart-related causes of chest pain. 3. Why is fever not helpful in diagnosing chest pain? Fever can occur in conditions like pneumonia or a pulmonary embolism, PE, which may cause chest pain, but fever alone is not specific to heart problems. 4. Why is shortness of breath not always helpful in diagnosing chest pain? Shortness of breath can occur with heart conditions, but it also happens with lung diseases, anxiety, or infections. It is often associated with poor prognosis, especially when combined with chest pain and needs further investigation. 5. Why is sweating or anxiety not helpful in diagnosing chest pain? Sweating and anxiety can be linked to many causes of chest pain, such as heart issues or stress. However, these symptoms alone don't provide enough information to pinpoint the cause. Diagnostic tests for chest pain. 1. What is the best initial test for chest pain? The best initial test for all forms of chest pain is an electrocardiogram, EKG. This test measures the electrical activity of the heart and helps detect abnormalities that could suggest heart problems. 2. How reliable is the EKG in an office or outpatient setting? In a non-hospital setting, like a doctor's office, the EKG is often normal if the patient is not having an active heart attack or other serious heart event. However, it is still important to perform the EKG before moving on to other tests. 3. When are cardiac enzymes like CKMB or troponin used? Cardiac enzymes, like CKMB and troponin, are most useful when evaluating acute chest pain in an emergency department setting. They help detect if there has been damage to the heart muscle. In chronic or stable chest pain, these tests are not appropriate. If the patient has acute chest pain in the office, the correct response is to transfer them to the emergency department. 4. What is stress, exercise tolerance testing, and when is it used? Stress testing is used to evaluate chest pain when the cause is unclear and the EKG isn't diagnostic. It involves having the patient exercise, usually on a treadmill, to increase the heart rate and see if the heart shows signs of ischemia, lack of oxygen. The exercise should get the patient's heart rate above 85% of the maximum, which is calculated as 220 minus the patient's age. 5. How is ischemia detected during a stress test? Ischemia is detected by looking for ST segment depression on the EKG during the stress test. This shows that the heart is not getting enough oxygen during exercise. 6. What should you do if you cannot read the EKG during stress testing? If the baseline EKG is abnormal, due to conditions like left bundle branch block or pacemaker use, it can be difficult to detect ischemia. In such cases, you should use other methods, such as nuclear isotope uptake using thallium, or sestamibi, which shows how well the heart is being supplied with oxygen. Echocardiography, which looks for wall motion abnormalities, problems in how the heart's walls move when the heart contracts. 7. How do nuclear isotopes help detect ischemia? Nuclear isotopes like thallium are taken up by normal myocardium, heart muscle, just like potassium is absorbed into cells. If the heart muscle is healthy and well perfused with blood, it will pick up thallium. If there's a problem, like ischemia, lack of blood flow, the heart will not absorb thallium properly, showing up as decreased thallium uptake in the imaging. 8. What is the significance of wall motion abnormalities? Wall motion abnormalities, dyskinesis, akinesis, or hypokinesis, mean the heart wall doesn't move correctly. This can be a sign of ischemia or a previous heart attack. Ischemia is reversible, so the wall motion will improve with rest, normalizing after exercise. Infarction, a heart attack, causes permanent damage, so the wall motion abnormalities do not return to normal. 9. What is the difference between ischemia and infarction? Ischemia is a temporary lack of oxygen in the heart muscle, which can be reversed with rest, shown by recovery of wall motion or thallium uptake. Infarction is permanent damage due to a heart attack, where the heart muscle doesn't recover and the abnormalities remain even after rest. 10. What precautions should be taken with stress testing in patients with asthma? Dipyridamole is a medication sometimes used in stress testing, but it can cause bronchospasm, narrowing of the airways. It should be avoided in patients with asthma. What to do if the patient cannot exercise? 1. What should be done if the patient cannot exercise for a stress test? If the patient cannot exercise, you need an alternate method to increase their heart's oxygen use to provoke ischemia. This can be done by using medications that mimic the effects of exercise. 2. What are the alternatives to exercise for increasing myocardial oxygen consumption? Two main alternatives are persentine, dipyridamole, or adenosine combined with nuclear isotopes, like thallium or sestamebe, dobutamine combined with echocardiography. 3. How does persantine, dipyridamole, or adenosine work? Persantine, dipyridamole, or adenosine increase the heart's oxygen demand by dilating the blood vessels, which mimics the effect of exercise without the patient needing to physically exercise. When combined with nuclear isotopes, like thallium or sestamebe, it helps detect areas of the heart that are not getting enough oxygen, ischemia. 4. How does dobutamine work in stress testing? Dobutamine increases the heart's oxygen demand and can provoke ischemia, lack of oxygen. The ischemia can then be detected by looking for wall motion abnormalities on an echocardiogram. This includes dyskinesia, inability of the heart wall to move properly, hypokinesia, reduced motion, or akinesia, complete lack of movement. 5. What are contraindications to using dobutamine for stress testing? Dobutamine should not be used in patients with ventricular arrhythmias, irregular heart rhythms that start in the lower chambers of the heart, severe hypertension, very high blood pressure, left ventricular outflow obstruction, a blockage or narrowing in the heart's main pumping chamber. Patients on beta blockers should temporarily stop taking them before the test. 6. What should be done before administering a dipyridamole stress test? Before giving dipyridamole, it's important to stop caffeine. Caffeine can interfere with the test's results because it affects the blood vessels and can mimic the effects of exercise. When reversible ischemia is found on a stress test 7. What does it mean if a stress test shows reversible ischemia? If the test shows reversible ischemia, it means the heart muscle is not getting enough oxygen during the test, but it can recover when the stress, like exercise or medication, is removed. This suggests that the tissue is still alive and can be saved with treatment, such as revascularization, restoring blood flow to the heart. 8. What should be done if reversible ischemia is found? If reversible ischemia is detected, the next step is to perform angiography, a type of imaging test, to look at the heart's blood vessels. This will help determine whether the patient needs bypass surgery, angioplasty, or treatment with medications. 9. Why is angiography important after reversible ischemia is found? Angiography helps doctors see the exact location and severity of blockages in the coronary arteries. The type of revascularization treatment, like bypass or angioplasty, depends on the anatomy of these blockages, irreversible versus reversible ischemia. 10. What is the difference between reversible and irreversible ischemia, like revascularization? Irreversible ischemia, or infarction, means the heart muscle is dead or severely damaged, and no treatment can restore its function. 11. Why isn't revascularization helpful for irreversible ischemia? Irreversible ischemia refers to dead heart tissue, often due to a heart attack. Revascularization won't help because the tissue can't be revived. Revascularization is only useful for reversible ischemia, where the heart muscle is still alive and can recover. 12. When should revascularization be done? Revascularization, bypass or angioplasty, should be done when there is reversible ischemia, as it can save the heart tissue and prevent further damage. What is coronary angiography? 1. What is coronary angiography used for? Coronary angiography is a test used to detect the anatomic location of coronary artery disease, CAD. It helps identify where the arteries in the heart are narrowed or blocked. 2. How does coronary angiography help in treatment decisions? It helps decide whether surgery, angioplasty, a procedure to open blocked arteries, or other revascularization methods are needed to treat CAD. 3. When is angiography used instead of other tests? Angiography is used if non-invasive tests like EKG or stress testing are unclear or inconclusive. How accurate is coronary angiography? Angiography is considered the most accurate method for detecting coronary artery disease. 5. What does angiography determine in terms of treatment? It determines whether the patient should have bypass surgery or angioplasty. Stenosis, narrowing, and its significance. 6. What does stenosis mean in coronary artery disease? Stenosis refers to the narrowing of the coronary arteries. It can reduce blood flow to the heart muscle. 7. What is the significance of stenosis less than 50%? Stenosis less than 50% of the artery diameter is considered insignificant and usually does not require surgery or angioplasty. 8. When does coronary artery disease typically require surgery or angioplasty? Surgically correctable disease typically starts with at least 70% stenosis, narrowing of the artery. What is Holter monitoring? 9. What is a Holter monitor? A Holter monitor is a portable EKG device that continuously records the heart's rhythm over a period of 24 to 72 hours. 10. What does a Holter monitor detect? It mainly detects rhythm disorders such as atrial fibrillation, atrial flutter, premature beats, or ventricular tachycardia, abnormal heart rhythms. 11. Does a Holter monitor detect ischemia? No, a Holter monitor does not detect ischemia, reduced blood flow to the heart, and is not used to evaluate the ST segment of an EKG. 12. What is Holter monitoring primarily used for? It is primarily used for evaluating heart rhythm and diagnosing arrhythmias. 13. When are enzymes like troponin used in diagnosis? Cardiac enzymes, such as troponin, are used to evaluate acute coronary syndromes, ACS, which are conditions like heart attacks or unstable angina. 14. When are serial troponin measurements done? Serial troponin measurements are taken before a stress test to assess if there has been damage to the heart muscle. 15. What is echocardiography used for? Echocardiography is used to evaluate valve function, how well heart valves work, wall motion, how well the heart's walls are moving during contraction, ejection fraction, the percentage of blood pumped out of the heart with each beat. 16. What is exercise tolerance testing, ETT, used for? ETT is used to evaluate stable patients with chest pain when the cause is unclear. It is not used in acute coronary syndrome, ACS cases, where the diagnosis is already clear. 17. When should a patient not be put on a treadmill for a stress test? A patient should not be put on a treadmill if they are currently experiencing chest pain, as this may worsen their condition. Treatment for chronic angina. 18. What medications are most concerned with lowering mortality in chronic angina? The most important medications to lower mortality in chronic angina, not acute coronary syndrome, are aspirin, beta blockers. 19. Does USMLE Step 2 CK focus on specific doses of medications? No. The exam focuses on knowing which medications are used, not the specific doses. 20. What form can nitroglycerin be used in chronic angina? Nitroglycerin can be used in forms such as oral transdermal patch for chronic angina, sublingual paste or intravenous forms for acute coronary syndromes. 21. What is the role of antiplatelet therapy in stable CAD? In stable coronary artery disease, CAD, patients usually need aspirin alone unless they have a stent, in which case they may need additional antiplatelet medications. Medications in heart failure and CAD 22. What is the role of ACE inhibitors, angiotensin receptor blockers, ARBs, in heart failure? ACE inhibitors or ARBs are used in patients with low ejection fraction or systolic dysfunction when the heart doesn't pump blood effectively to reduce mortality. 23. What are the side effects of ACE inhibitors? Cough is the most common side effect of ACE inhibitors, occurring in up to 7% of patients. They can also cause hyperkalemia, high potassium levels. 24. What happens if a patient experiences a cough with ACE inhibitors? If a patient develops a cough with ACE inhibitors, they may be switched to an angiotensin receptor blocker, ARB, but both classes of drugs can cause hyperkalemia. 25. What is hydralazine used for in heart failure? Hydralazine is a direct-acting arterial vasodilator used to decrease afterload, resistance the heart has to work against, in patients with systolic dysfunction, heart failure. It improves heart function and reduces mortality. 26. How should hydralazine be used in heart failure? Hydralazine should be used with nitrates to dilate coronary arteries and improve blood flow to the heart while reducing afterload. Antiplatelet therapy, alternatives. 27. What are the alternatives to aspirin in antiplatelet therapy? Ticagrelor, prasugrel, or clopidogrel can be used as alternatives to aspirin for patients who need additional antiplatelet therapy, especially those with stents. Beta blockers 1. What are beta blockers used for in heart disease? Beta blockers are the first-line therapy for stable angina, which is chest pain caused by reduced blood flow to the heart. They are used to help relieve symptoms. 2. How do beta blockers work? Beta blockers work by decreasing the heart's contractility, how hard the heart works, heart rate, and the heart's oxygen demand. This helps the heart use less oxygen, which can reduce chest pain. 3. How does a lower heart rate help in angina? A lower heart rate allows the heart to spend more time in diastole, the phase when the heart is relaxed, which helps improve coronary perfusion, blood flow to the heart muscle. 4. Are all beta blockers equally effective for angina? Yes, all beta blockers are equally effective in treating exertional angina, chest pain triggered by physical activity. 5. Why are non-selective beta blockers rarely used in cardiology? Non-selective beta blockers have more side effects, so they are rarely used in heart-related conditions compared to selective beta blockers. Lipid management 6. What is the goal for LDL cholesterol in patients with coronary artery disease, CAD? The goal for LDL cholesterol, often called bad cholesterol in patients with CAD, is to keep it below 70 milligrams DL. 7. When should statins be started in primary prevention? Statins should be started in people with a 10-year risk of CAD greater than 7.5% to reduce the risk of heart disease. 8. What are the different types of statins, and how do they affect LDL levels? Statins come in different intensities based on how much they lower LDL. High-intensity statins, e.g. atorvastatin, rosuvastatin, lower LDL by more than 50%. Moderate-intensity statins lower LDL by 30–50%. Low-intensity statins lower LDL by less than 30%. 9. What are some examples of statins? Examples of statins include high-intensity atorvastatin, rosuvastatin. Other statins: fluvastatin, lovastatin, pitavastatin, pravastatin, simvastatin. Statin use in various conditions. 10. Which conditions require statins to lower LDL cholesterol? Statins should be used in patients with coronary artery disease, CAD, peripheral artery disease, PAD, carotid artery disease, Aortic disease, disease of the aortic artery, stroke, heart attack, MI. 11. What is the main takeaway about statins in lipid management? Statins are the only medication shown to have a definite mortality benefit. They help save lives in managing hyperlipidemia, high cholesterol, in conditions like CAD, stroke, and PAD.